I am Timothy Donahue. I am a professor of surgery and chief of the Division of Surgical Oncology. I'm vice chair for surgical cancer care at the David Geffen School of Medicine and UCLA Health. Treatment of patients with borderline resectable and locally advanced cancer. First to start off, there are a number of different definitions of borderline resectable versus locally advanced. In general, those with borderline resectable cancer or the borderline resectable tumors, can involve the superior mesenteric vein or the portal vein, cause distortion of the vein, or involve a short segment of the hepatic artery or less than 180 degrees of the superior mesenteric artery. Whereas locally advanced tumors involve, more of the superior mesenteric artery, so greater than 180 degrees, essentially to encase the superior mesenteric artery or involve the celiac axis, which are all very essential blood vessels that are located near the pancreas. About a third or so patients who present with pancreatic cancer present with either borderline resectable or locally advanced disease. And the treatment for them is rather than to take them to surgery up front, but rather to treat them with chemotherapy and or radiation therapy before surgery. The rationale for doing so is that the chemo or the treatment sometimes can cause the tumors to recede away from the blood vessels, which can make the operation less complex and more straightforward. And also while patients are being treated with chemo and or radiation, it gives us a period of time where we're able to watch them and see the biology of their tumor and make sure that metastases do not develop, which would have told us or which would tell us that upfront surgery was not what they needed for their treatment, and what they needed was some form of systemic therapy because pancreatic cancer, has a high predilection for systemic spread of metastases. Those borderline resectable tumors, so those are the ones that, grow to just partially involve the vasculature, or less of it around the pancreas. The treatment algorithm for them is to give these patients upfront chemotherapy, usually with FOLFIRINOX or gemcitabine and Abraxane. And this is usually given in about 2.5 or 3 month kind of intervals, with reassessment usually after 2.5 or 3 months. These patients are considered potentially curable, and so this isn't a huge space where there have been a lot of clinical trials, or at least early phase clinical trials, which are reserved for more advanced disease like locally advanced tumors or metastatic tumors. So as I said, a course of upfront chemotherapy for either 3 months or 6 months, usually 3 or 4 months, and then the consideration of a radiation therapy before surgery. Many high volume centers were using radiation therapy for pancreatic cancer, whether that be standard chemo radiation, or SBRT, stereotactic body radiotherapy. But there was just recently an Alliance study that was read out, which was the Alliance A021501 study, which was a phase 2 study, prospective randomized study that randomized patients with borderline resectable tumors to either 8 months of FOLFIRINOX chemotherapy and then surgery, or 8 cycles of FOLFIRINOX chemotherapy, then surgery, or 7 cycles of FOLFIRINOX chemotherapy, then SBRT, and then surgery. There was essentially no difference in the rates of margin negative resections or survival between the two groups. And in fact, the margin negative resection and survival favored the chemotherapy alone group. So I would say that because of this study, at least the most recent trend, and this is only within the last few months, is away from radiation therapy or SBRT therapy for patients with borderline resectable tumors. And so the algorithm really is chemotherapy and then surgery. For locally advanced tumors, these patients have tumors that have grown to involve more of that vasculature and have more advanced disease. And this is a space where there is more room for clinical trials because these patients have a much lower chance of being so-called curable, but there are cases where it is possible when a margin negative resection is done. I would say the trend for these patients is to give them more chemotherapy up front. So the NCCN, National Comprehensive Cancer Network, pancreatic cancer subgroup guidelines are for patients with locally advanced disease to get 4 to 6 months of chemotherapy up front, followed by either chemoradiation or SBRT, and then a consideration for surgery after that. Radiation therapy is still part of the algorithm for these patients. The Alliance study that I mentioned did not include locally advanced patients. The rationale for the radiation therapy in these patients is that, as I said, these tumors have grown to involve more of that local vasculature, particularly the arteries in the area, the SMA, the celiac axis, and it's thought that radiation therapy gives the patients the highest chance for a margin negative resection, which has been shown to, correlate with better overall survival in patients with locally advanced tumors. To summarize, borderline resectable, I would say upfront chemo, shorter dose of chemo, not necessarily total neoadjuvant therapy, radiation, less of a role because of the recent Alliance study. Locally advanced patients, the move is toward neoadjuvant chemotherapy, total neoadjuvant chemotherapy, so for even up to 6 months, followed by conventional chemoradiation or SBRT prior to consideration for surgery. All in all, about I'd say 3/4 of patients with borderline resectable disease, maybe 75 to 85%, do undergo a operation, a majority of whom do have margin negative resections, and about a quarter to a third, maybe around a third or so, patients with locally advanced disease, at least in historical studies, wind up making it to surgical resection, with a majority of them also having margin negative resection. So, constantly changing treatment approaches to patients with these stages of disease, but the resection rates are increasing and the survival is also improving with time.